Dunkin' Donut money. Sorry. So I want to personally thank everybody who put this together. It takes a lot of, yeah, we have Pete and Milton that's not here where they're at. So yeah, Pete's probably over with the vendors. So I just want to thank everybody, all the hard work that goes into this throughout the year. I appreciate it. And give these guys a round of applause. All right. So the next speaker, we have Teresa and Drew from SythPop AI. They are going to talk about remote patient monitoring. Drew's listen really good because when I'm speaking, I kind of tie into some of it, and I'll have a little quiz for you.
Yeah. Hey everyone. Oh, we're smiling. If we were smart, we're smiling. Yeah. Sorry, everyone. We need a second. Okay. Oh, okay. So the 8:15 slide. Yay. Everyone got the coffee? You ready? Ready to hear about like billing codes and stuff? Your brain's okay, cool. So I'm Drew. This is Teresa. Thank you for coming here, and thank you, Robert, for letting us speak. Been an amazing lineup of speakers, and we're honored to be here. I want to make sure that this works. It should work, right? It should work, right? This is fun. This is fun.
Wow, it's crazy.
Yeah. All right, and that's our talk. All right. Next one. Okay. So go ahead. Yeah. Wait, no, it's not. Just talk closer.
Hi everyone. I'm Teresa. As you can probably imagine, not true. I have my CCSH from the Board of Registered Photographic Technologists, but I am not registered photographic technologist. I took a different pathway to get my CCSH really because I saw so much need for patient education and support. Drew really founded me to get a credential. It really was the only credential out there that's anywhere close to what I was looking for to become a sleep coach. And that is really what I do now. I'm completely obsessed with sleep. So going back, I spent about 15 years in healthcare, sales and consulting, various different fields. As soon as I got into sleep, I was absolutely hooked. I never wanted to do anything else. And I started feeling other people were hooked too. And you guys probably have this experience where you're talking to friends or family or random people at the bar. And as soon as they find out you're asleep, they have so many questions. Typically, it has nothing to do with what I do for work, but everybody has questions. And over the years, I've worked with hundreds of dentists and physicians who have treated thousands of patients. And I am still overwhelmed by how little the patients know and understand all the time, in part due to our incredible healthcare system that burdens our clinicians, but I really wanted to do more. So about 2 years ago, I see better MIC, started on social media, like Emma mentioned yesterday, just to get some awareness and education out there. If any of you guys have looked on social media, there's a ton of garbage out there about sleep. A lot of it is outdated or incorrect.
There's the 5 a.m. club. You guys see that? It's encouraging everyone to wake up at 5 a.m.
A lot of stuff out there, but I just really wanted to help get some information out there. Some basic tips and tricks, of course not medical advice, but it was really a place to start, and I've actually done a really nice community of people who need and want this information. Through that, thankfully I've been able to participate in a lot of podcasts and articles, things like that. AADSM, BRT, and actually Germany, I just finished the World Science Therapy for Sleep Technologist track for the AASM, which I believe is available, but we're doing a webinar in about 2 weeks as well.
And I'm Drew. I'm an associate tech. I spent doing this for 20 years, spent 10 years running overnight sleep studies, rates and sleep labs. But I'm not going to talk about that. I have a similar story to a lot of you. The reason why I'm up here, the reason why I want to talk about patient monitoring is this is actually personal. My grandfather had sleep apnea and was a horrible CPAP user, as a lot of grandfathers are, and he passed away. He had really bad Alzheimer's at the end, and I used to work at Mount Sinai. They did a lot of research linking untreated OSA to neurocognitive decline. And then more recently, my mom was a CPAP user. My mom passed 2 years ago, but I know without a doubt that if my mom didn't have a sleep tech as a son, making mask changes, helping her with that, she would never have used that machine. And I know she would pass much earlier. So what we're talking about here, RPM, I did that for my mom, like for years. And now I want to show, we're here today really to show you how this could be something that's great to everyone. So yeah.
So, and why are we doing this? None of this is going to be shocking to you guys. We truly believe that the current OSA ecosystem needs to evolve. Ordering providers are overwhelmed, treating providers are under-resourced, and most likely underpaid. Sleep patients are frustrated, and we all know that a lot of people don't even become sleep patients. All these numbers about undiagnosed patients, they just never get to where they want to be. So we know that sleep coaching can support all three of these groups of people to reduce clinical burden and, of course, improve outcomes, which is everybody's goal.
So we are on Zoom, so if you want to step into the camera, of course. Yeah, we love you guys. We also want to be okay. Anyway, so everyone has to do this slide. Conflict of interest. We do own Sleep Better NYC. That's an RPM company. We work for an AI company called SythPop. I will say right now, I don't like saying conflict of interest. I worked with a doc who calls it his confluence of interest, which I really love. You guys sitting in this room, you're the experts. You know sleep, and so it's we have to work with industry. We have to help guide that, and so bring all the knowledge you have. So these are our confluences of interest. I don't know, that's my little soapbox thing. Here we go. Go ahead.
Okay, so just a quick overview of the objectives here, so you know what you're getting into, so you can get your CE. We'll do a review of the history of CCM, critical care management, transitional care management, and PCM, principal care management. All of this to me is pretty boring, but we need to cover it super quick to understand how remote patient monitoring came to be and has evolved. Of course, because we are sleep coaches, we want to explain how sleep coaching in the clinical setting can reduce clinician burnout and increase therapy adherence. We'll do an overview of the regulations and guidelines of RPM. This is typically where we get a lot more questions. It's the billing, it's the money involved here, specifically for sleep apnea. And then we'll talk about what we think is the future in sensor technology and AI. And of course, we know it's early and some of you might not even be paying attention, which is fine, but here are the topics. So you know when to look up again and start taking some notes. Of course, we'll cover what is remote patient monitoring. We'll talk about how it benefits everyone, the patient, clinician, and the DME. And then of course, who is doing this remote patient monitoring? We all have lots of things to do, so who's actually doing this? We'll go over clinical workflow examples, including the billing codes throughout this workflow. And again, just get into the future and talk a little bit about value-based care and how we think we can scale this.
All right, let's get into this. So, first CPAP machine was developed in the 1980s. Anyone know who made the first CPAP machine? Yeah, what country was he from? Anyone know? Australia, good. Yeah, he gets a. Can we give him a prize? No, we don't have that stuff. Okay, you got it. Good. Okay, so CPAP obviously incredible. And then it wasn't until we had wireless technology that paved the way for what we're doing here. Early 2000s, we had Wi-Fi enabled CPAP machines. Then we got the cellular modems eventually. Right now, that's something we all take for granted. You just log into AirView, data, but this really paved the way. This was groundbreaking. It was just incredible. We can actually give the patients a treatment and see if they're using it and if it's working. That paved the way for what we're doing. However, even when all that stuff happened, we had access to it. We didn't have the infrastructure in place, the reimbursement infrastructure to make that viable, to really know on a day-to-day basis how our patients were doing. And so we did our best. I'm going to use this. Here we go. I'm proud of this slide because I made some sports analogies here, and I use 3 different sports. Okay. So here's how we handle this right now. So we have the buzzer leader, where we rely on the DME company to monitor the compliance, and like 10 minutes before the patient walks into the office, you're texting the DME rep and saying, quick, can you fax me their compliance report? So this is really low effort on the practice part, but it's not great, not effective. I've seen so many patients walk in to see like the docs, and the doc's like, all right, so let's see how you've not used it at all in the last 90 days. Okay, cool. And now they're trying to play catch up. So that's the buzzer beater. The 12th man, that's a football ref. Yeah. Okay. So that's when you wait for the patient to say, hey doc, I'm having trouble. All right. So that's great. It rewards the patients who really, really want to use it, but it hurts the less confident patients who don't want to be like, hey doc, I'm not doing the thing you told me to do. And then finally, we have the complete game, and that's where you assign personnel within the practice, within the sleep lab, to monitor the compliance and intervene. So obviously you get timely interventions, but it ties up your essential. Does anyone here work for a place that does that? That you are on a daily basis looking at patient compliance? Not DME companies. Come on, Eric. Right, because you're not getting paid for it. I'm just gonna be honest with it. That's why. Oh, okay, we're gonna tell you how to do that. So that's where this is the best we've been able to figure out until we get to what we have here. So let's quickly talk about the history. We have transitional care management. This started in 2013. That was, I'm being told I'm talking too fast, and I do talk fast. I'm gonna slow down a little bit. Okay, we have transitional care management. That was what created in 2013. That was to help patients who were discharged from the hospital. It was additional codes to compensate healthcare workers for helping them with that transition. Then we have chronic care management. All right, that was in 2015. That's when you had really sick patients who had multiple comorbidities. These codes were used when we were managing those patients. And finally, we had principal care management. That was in 2020, but that was just for one chronic condition, for instance, sleep apnea. However, the big game changer was RPM. So RPM came out in 2019. It was originally when it was introduced by CMS, by Medicare. When it was originally came out, you had direct supervision. So you had to be in the same location as the physician. All right, 2021, they made an update. They said general supervision. So that means that a sleep tech can help a patient, and as long as the physician is signing off on everything you're doing, you don't have to be in the same location as him. We're also going to talk about remote therapy monitoring, not as much as RPM, but so that was introduced in 2022, originally with direct supervision, and then that made the same jump over to general supervision. So as we dive into this, the reason why I have the slides, I want to keep in mind that this has been around since 2013 in some form. All right, we're 10 years into it, and we're finally making some traction and being able to use this in sleep medicine.
So back to the good stuff. What is remote monitoring? Remote patient monitoring typically refers to remote physiological monitoring, but people really use it interchangeably. They just call it RPM, but usually we're talking about remote physiological monitoring when we say that. Although remote monitoring in general, of course, also includes remote therapy monitoring or RTM, like Drew just mentioned. All of it really encompasses the use of digital technology to monitor and capture data, healthcare, medical and other health data from patients that is electronically transmitted. And this information, of course, is transmitted to healthcare providers for assessment and, when necessary, instruction and recommendations. And I want to really emphasize that last part is the recommendations and the instructions, because what is the point of all of this work, of all of this monitoring, of all of this data collection if we're not doing anything about it? And that is really the goal of remote patient monitoring. So what's the difference between RPM and RTM? What is the same? We'll go through this just a little because, again, they're not interchangeable, but there are a lot of similarities. So for both, we are going to require a medical device, and I'll talk a little bit more about this in a minute. As you mentioned, they both allow general supervision, so you don't have to be in the same physical location as the provider. Both required to collect and monitor at least 16 days of data out of 30 days.
And you can only bill RPM or RTM every month for each patient. Now we'll talk a little bit more about the medical device part, because this is a discussion for anybody who is talking about RPM, and it is a hot topic, but as far as we know right now, it is absolutely critical to use a medical device, even for RTM, according to the Federal Food, Drug, and Cosmetics Act. It's pretty easy for us to understand why you would need a medical device for physiological monitoring, but you do also need it for RTM. Advocates have urged CMS to define the type of technology that is covered by RTM. For example, we've suggested things like software as a medical device, AI, machine learning algorithms, but in 2023, CMS didn't really say yes or no to any of those, leaving it up to discussion and a bit more confusion. But as we know now, again, you need a medical device.
Yeah, basically they were like, you need a medical device. We're like, what does that mean? Like, we don't know. Yeah.
And that's where we are. So just a few key differences. Again, physiological data is for RPM, and RTM also allows for more subjective data. RPM requires it to be automatically transmitted. So that's that CPAP data going into AirView or iCode Connect. And then we use a system called Monitor that translates all that data for us, whereas RTM allows the patient to submit that information. So that might look like a daily questionnaire pushed to their phone, for example, about their symptoms and their pain, for example. Back to the general supervision part that you mentioned, while they both occur under general supervision of a physician, RPM requires that that physician is the entity that is submitting the claims for this. So again, they review the information, the work that you do, and then they submit the claims, or the practice submits the claims. On the other hand, RTM does allow for qualified healthcare providers, a nurse practitioner, a PA, physical therapist, to bill those codes as well. Now, RTM, though, is very specific as of now for musculoskeletal, respiratory, or CBT, whereas RPM is condition agnostic. And we've come across a lot of RPM in all different medical fields, spine, cardiology. A lot of people are doing this. It just, as we do in sleep, it seems a little bit overcomplicated when it comes to sleep. So it is still newer in sleep medicine.
Okay, so let's start at the beginning. These are the codes. You can take some pictures here. We can take pictures later if you want, but these are the codes that are up there. It basically is split out into kind of 4 segments here. So the first one is setup and education. And so you'll use that's when you provide the device, you educate the patient as to what RPM is. Once the patient is on board, the next step is the 99454. So that covers collecting and analyzing that data. That's where we said that 16 out of 30 days. That's the 99454. And then finally, the good stuff is when we get to the 457 and 458. So this is when you're actually reaching out to the patient, you're coordinating the care, you're calling them, you're saying, hey, Mr. Jones, did you use your machine last night? Can we talk about this, or anything I can do to help? So that what happens is you record the amount of time you spend in synchronous communication. So that's either video or phone call, and the care coordination. So that might be communicating with your DB company to say, you know, we did a virtual mask fitting. It's still leaking. As much as we're trying, we need a new mask, or we need a mask change, okay, or a size change. Now the RTM goes in direct parallels to all these. The one place where it's different is, like Teresa said, right now it's respiratory, musculoskeletal, CBT, so they have 3 different codes depending on how you're using our RTM code. All right, and we're going to go a little bit more into these later. We've given this talk a couple of times, and I do want to leave some practical tips for you at the end. So if you're interested in this, you might be able to do it in your own place, and we'll talk about that soon.
So sometimes I will explain RPM is basically sleep coaching in a clinical setting. So Drew and I are sleep coaches. We also have a love-hate relationship with that term, because again, maybe you've heard of sleep coaches for babies. That's not at all what we do. We don't talk to children at all, ever.
Yeah,
maybe.
I want to sleep coach.
No, we don't work on children at all. But that's what people typically think of when they hear a sleep coach, especially if you're going to the internet for it. You might have seen, again, so-called sleep coaches online. Maybe they overcame insomnia themselves and they have really great intentions, but they're, telling people to take a supplement to cure their insomnia, or sleep hygiene will help your sleep apnea, which of course we know is not true. But despite all that, coaching is a term that people generally understand, and it really is what that one-on-one care is based on. So we really like this quote from the former president of the AASM, Dr. Nathaniel Watson. He says, coaches help people, they help them set goals and achieve those goals. They provide encouragement along the way. So sometimes Drew will actually explain sleep coaching to non-sleep people as personal trainers for sleep, which, they almost immediately will understand what we do or have an idea. But what does it really mean? Like, what is it? Who does it? This is, of course, our opinion, but what we have seen in the field. What is a sleep coach? Who is a sleep coach? We prefer people who have the CCSH or the RPSGT credentials. We only hire these people to be our sleep coaches, mostly because we're very heavy in OSA. But we've seen a lot of other people who have experience, especially talking to patients in a clinical setting, which is what we think is really important. This is not an exhaustive list. Of course, there are others out there. And I also do like to mention, although at this point we haven't worked with people who don't have a clinical credential, we don't have to totally write those off either. It really depends on what the role of that person is. Now, if they're just helping with some general sleep hygiene or doing some intake, I don't think that we need them to have a license. And on that note, with RPM, because we're not making any clinical decisions without any general supervision, it's actually not necessary to have any kind of license to provide RPM services.
Yeah, quick question. How many people live in a state where you have to be licensed to be a sleep tech? Anyway, yeah. Cool. Yeah. So that's what we're talking about. You cannot be a sleep tech in that state without that license. RPM does not have the same regulations. Because we're paid to police our scope of work.
Yeah, and we get that question a lot. We have spoken to a lawyer about it. We've looked at every single state. We cannot find anywhere that says differently, but obviously I am a sleep coach and not a lawyer, so take that with a grain of salt. The setting. So I think the most obvious would be a sleep medicine practice, someone who helps educate the patient while the doctor is running around or the nurses are running around doing millions of other things. We all know that patients are talking more to people like us than they are to their physicians. They're a little bit more comfortable with that. Dental sleep practices, this is another great place, and more we are encouraging, and we're hearing in other conferences that they want to hire sleep technologists and people like that in their practices to help coordinate care and educate their patients. There are some really incredible dental hygienists who do these sorts of things. Emma mentioned yesterday myofunctional therapy, again, sort of a newer developing field, but they're very, very passionate about sleep and airway. It makes great sleep coach. DME companies, we see a lot of them now do have sleep coaches, and that has evolved over the years too. We've seen them call sleep coaches many years ago, but they were really just sort of like switching out masks. Now they do have a little bit more touch points as far as we see. Sleep testing facilities, making sure that patient, after they get ordered even an HST, that they're actually taking the HST, that they understand how to do it, that they know after they take it, they actually then have to go and get treated. All these things that are sort of minor, but we know there are so many points where patients can just fall off, and that's where sleep coaching really helps. Commercial industry too is something really interesting. It is very relevant. People are talking about this all the time, the employee wellness programs. Of course, that's a little bit more complicated. It's a totally different realm than anything in the clinical setting, but people are looking for experts, and you guys are the experts. Now, lastly, the scope of work here. This is something that is super important. I think we've probably alluded to it and talked about it already a little bit. What we do is just as important as what we do not do. And we try to make this very clear, especially because we all need to not just collaborate, but we actually need to work with physicians and all sorts of clinicians to make our job work and, to be legally practicing. So in scope is clinical education. After a patient has been diagnosed, we can explain to them, what does that actually mean? How does that relate to them in their life? care coordination, talking to the DME, talking to the physician, if they are recommended a different form of therapy, maybe helping them look up other providers of that, maybe a sleep psychologist, for example. Therapy monitoring, of course, what we're talking about here, who better to look at daily data than people who understand what exactly is happening in their CPAP machines. And then out of scope, again, it's fairly obvious, but I have to say it anyway. We're not making any clinical diagnoses here. Most diagnoses, thank you for correcting me. Most of the patients we work with are already diagnosed with sleep apnea, of course. We might recognize signs of other conditions, and of course, we're gonna note that in their chart and talk to their physician, but we are never, ever going to tell the patient that. We're never going to insinuate that they have any kind of diagnosis or tell them that they do if it has not already been diagnosed. We're not making any decisions. And even when it comes to things like mask changes or pressure changes, we are going to talk to the physician and they will decide, of course, if they're going to write that prescription.
Are there any physicians in the room actually? Okay, cool. We probably need to slide that. This is just to like make it feel like.
Yeah. Okay, great. Excellent. And of course, we're not prescribing anything, which I think y'all can't do anyway. So this is a OSA clinical workflow. You know, it might look a little bit different where you are in your practice or sleep lab, but you know, of course, this is just generic, a typical workflow as we see it. And before I go through it, I do want to make a quick note that just designing this slide alone was so incredibly tedious and annoying to get the colors right and to remember who's doing what. And there are some where I probably could have added more colors because it's like very scrambled and mixed. And it just really is a great analogy for sleep medicine today and the system. There are so many touch points. There are so many places where there's just room for error. And you can imagine why patients are frustrated and so are healthcare providers. So we'll walk through this quickly again, because I know that you know most of this, but of course the physician's going to do the clinical evaluation of the patient, OSA education as well, tell them what OSA is. I also made this the color of the patient because we know that patients are only absorbing about 40% of what they are told for the first time in the doctor's office. And we also know that as soon as they leave, they're going to Dr. Google and they're asking their uncles and their sisters and their friends about OSA instead of their doctor. Then, of course, testing coordination. We assume that in most places it's their practice staff, of course, coordinating with the patient based on their timing, if they're picking it up, if they're mailing it. Results delivery, most likely the physician, potentially reinforced by the practice staff. Of course, the physician is prescribing therapy, and then the treatment therapy coordination comes next, and that's where our DME comes in. Also trying to get a hold of the patient, playing telephone tag back and forth, making sure things work. Daily monitoring is grayed out because that doesn't really happen right now. So troubleshooting and interventions, again, you know, this is one where I couldn't really get all the colors to work. DME is helping here, but more likely they are calling the physician for help. The patient's going online, they're trying to troubleshoot themselves.
They're looking at YouTube videos.
They're looking at
change the pressures themselves.
They're always doing that. Of course, if that doesn't work, what's next? Do they need a new mask? Do they need new therapy? Again, we see the DME here, we see the physician here. But what happens after that? What is the long-term monitoring? So again, obviously, it's pretty unlikely that we see much daily monitoring or long-term monitoring of these patients, even though we all know, the research has been telling us for a long time that it's pretty clear if the patient is going to be compliant and adherent and they're going to have good health outcomes after just a few days of getting their CPAP and, you know, within a few weeks of coaching even. But without a point of contact, a sleep coach, without timely interventions, then those patients just become part of those non-compliance statistics that we all know.
So let's see what this looks like with a sleep coach. Yeah. See all the pink there? Oh man, what a pink shirt.
I know, it kind of looks purple, but it is pink.
Yeah, this is supposed to be pink. All right. Here's our sleep coach shirt here. Yeah. We got a lot more pink. So this is where we envision we get the sleep coach stepping in. So obviously the first one is OSA education. I worked with a bunch of doctors at a pretty big health system, And one of the things I used to tell them is, you are a board certified sleep physician. You've been doing this for 20 years. You don't need to explain to a patient what obstructive sleep apnea is. That's so below your scope of work. When I was at the bar with them, I would actually say, I can do it better than you, so you should stop doing it. Let me do it. So anyway, sleep coach can explain it to them. We can help them understand the results of their sleep study and understand the health impacts of it. The grayed out ones we had, the daily monitoring, long-term monitoring, that's what we can do. We can make sure that the patient is okay in those first 3 to 7 days where we know that it's super, super important. We can also make sure that, 5, 10 years from now, when they've gained 50 pounds or they've had a heart attack or they're on a different medication, that they're still using their machine, that it's still treating their OSA. All of the troubleshooting interventions, it just gives them a single point. Oh no, I did a thing. There we go. So when it comes to this, these approaches, what we say is, if you are interested in this, you can try to work with a local practice. This can also be something that's outsourced. We do it completely remotely, working with patients here. So this is how we imagine the sleep coach role working, and this is how we've in practice seen it work. So we've kind of covered what remote patient monitoring is. We covered who does it, how it's done, but I guess we should have a slide, which I already prepared, as to why we do it here. So they're amazing benefits, all right? So the patient gets timely interventions. They get really good education, all right, and they have easy access. They know exactly what person. It's not, they reach out to the physician when they should reach out to the DME, or the DME to the physician. They have one person and we can triage them. The sleep techs, you guys in the room. So this is job security. This is what the future could be. I mean, you could be, if you're working in a sleep lab, I commend you. It's an incredible job. This is also something that you could consider. It expands your skills. You can learn a little bit more about sleep hygiene and maybe even help patients about insomnia. There are ways that you can like online courses you can take on that, and you're really making an impact rather than just identifying the problem. You can help fix it. Physicians, they get more empowered staff. Patients love this. We have patients who go in to see the doctor and be like, oh my gosh, like, I had trouble at first, but then, this woman, Teresa, reached out to me and was helping me for the first week, and now I can actually use my machine. It's amazing. So the doctor like pats us on the back and we feel good about ourselves. So physicians like this, and for those physicians who are actually having one of the techs do this, now they can actually be reimbursed. DME companies, we love you guys, really, really love you guys, but we also know that you're overburdened. So we can help improve the compliance for your patients. They again get that dedicated point of contact, and you have to devote fewer internal resources to this because we can do it, and the insurance companies will pay us for it. And maybe this one's a little bit wishful thinking, but on the payer side, they should be seeing the improved outcomes, that are reduction in failed therapy. We're not giving the fewer patients are being given a CPAP, and it's just being taken back from them in a couple months. And it's cheaper to have someone like us do this than for the patient to go back and see the physician time and time again, if we can help them. So we have given talks like this, and this is usually the point where maybe I think in the past we stop here and the hands will go up and they would start asking more about the billing codes. We're gonna do a little bit of a deeper dive into the billing codes right now. Okay. It honestly, it feels like all of you people just care about money, and it's really sickening to me. That's all. I'm just kidding. We're gonna talk about this. All right, so billing codes. These are the ones that we had that slide up earlier. This is probably not the best slide to pick up. What I will point out here is that 99453 is the one you bill once. All right, and the other ones you bill every month. Okay. So the first one, the 99453, that's when the order for RPM is placed. That's where the patient consents to it. That's where you educate them and give the device delivery. Now, this, when I say device delivery, I want to say this. This is not when they receive their CPAP. All right, the device delivery is when the healthcare provider gives them a device. As Teresa mentioned, we use software as a medical device called Monitor. There are groups that use a small, like a bell and ring or a sleep image ring or something like that. But it has to be a medical device. I'm talking too fast again. I want to slow down. All right, 99453 is how it starts. That's the first one you go. All right. So this really what this says is this is you educating and equipping the patient on all aspects of RPM. The next one is the 99454. This is how we're reimbursed for the effort to collect and analyze the data. As we said before, we need 16 out of 30 days to build this one. And hopefully, if we're doing a good job and we know what we're doing, we can help these patients, we can get them to that. It's kind of a low bar, but we also know that some patients, anyway, try and get 16 points of data in 30 days. You want this one? Yeah, okay.
Okay, so the next three rectangles are a bit confusing, so I'll try my best to explain. You see this middle one here, 99457. This is for 20 minutes total spent in monitoring, care coordination, and that synchronous communication. 99457 plus 99458. This is for 40 minutes total of all that work. And 99457 plus 99458, that would mean a total of 60 minutes of all that time and work that you're doing. So in our practice, in our business, we see this often using all of these codes, but really mostly in that first month. So in that first month is when we are introducing ourselves, we're educating the patient on what RPM is, what we're doing, what we're looking for. They have a lot of questions if they're using any of the apps like MyAir. We will have to have a video call with them or a phone call. And between all this work, maybe we are reaching out to the DME, maybe we are reaching out to the physician for things that we had talked about with the patient or things that they might need. So all of this time, again, is that monitoring, care coordination, and synchronous communication. So in that first month, for example, I'll try not to be tongue-tied here, but we do.
Yeah, that's the reason I gave this slide. Complicated.
And that first busy heavy month will be 1,99453, 1,99454, 1,99457, and 2,99458.
You got it?
And then after that, typically we'll spend significantly less time with that patient, with that care coordination. Of course, that's the goal. We don't want to waste our time. We don't want to waste the patient's time. You know, if we're working out with a patient for 3 months, I'm really, really hoping, and I don't think we've had this yet, that we're not spending 60 minutes a month on each patient, not because they don't deserve it, but hopefully at that point, they're comfortable, they're using their device, they have better sleep hygiene practices. So it typically goes down to 40 or 20 minutes after that. And then depending, of course, how long you want to keep them in the RPM program. Now, we work with patients who get a new CPAP prescription coming with an RPM prescription, even though they've been using CPAP for years. We have a patient now who's been using it for 9 years, but we will still talk to that patient in that first month and monitor them in that first month. You know, a lot can change for them over those 9 years. They have a new device, and you'd be really surprised. Even, you know, we see patients, oh, they've been on it for so long. I'm always thinking, oh, they're not going to want to talk to us. They're going to ignore all our phone calls. But typically, we get through 20 minutes at least with even those patients as well.
So yeah, we've got the past of RPM. This is the present. These codes are happening right now. They're being built right now. So let's talk about the future. That's the title of our talk, right? RPM past, present, future. So let's talk about the future here. So, you know, basically what we're saying is all we have to do is to give medical devices to millions of patients, spend 20 to 60 minutes each month with each of them to document everything we do. We have to track the health outcomes, right? That's super easy. That's scale. No, we can't do that yet. So how can this actually scale so that all the patients who have OSA can do this? A lot of this is just my conjecture, but I think it might start with the hardware. We've had talks with a lot of not just medical device companies, but consumer device companies. And the gap between medical devices and consumer devices is shrinking every single year. And I'm sure you've seen it. You know, Apple has FDA clearance for AFib detection and asthma too. Yeah, asthma. Fitbit has a similar thing. Wesper is a company that started off as a consumer device and then became a medical device. The Dream headband, that was a consumer device, and now it's used in clinical research. Oura Ring is about to release some, well, we can't say a lot, but they're going to release some pretty compelling evidence at the World Sleep Congress coming up in a couple weeks. So what I'm trying to say is tech companies are focused on this. The sensors, the actual hardware is getting cheaper and cheaper, so the consumer groups can add to these devices, and insurance companies are getting more open to it. Does anyone here get like a stipend or something from your insurance company if you walk a certain amount, or they are caring about this? So the vision I'm painting here is right now, as we said, probably 14 times so far, RPM requires a medical device. But what if that changes? What if that policy changes? What if we can have a diagnostic quality device already in the patient's home that they're all already wearing? And we can really, really know how they're sleeping and the quality of their sleep and trust it. Can anyone in this room tell me how that would be a bad thing for us to know that, for all of our patients to know that all this work we're doing to be able to actually track to see if it's working for them? You know, another thought here when it comes to the hardware is CPAP is the gold standard for OSA, and for good reason. I mean, it works, and we have, again, access to that data. But even that is changing when it comes to some of the other forms of therapy. I think we know 4 different oral appliance manufacturers are going to be adding in efficacy and adherence monitors within the next year. We know that implants, Inspire has a way to track the usage and efficacy of the device. Excite has a way to track how much they're using it. We're getting access to more and more of this data, and it's because of the advances in hardware. And that's just for OSA. I know we're here with sleep tests. We think we have this like idea that anyone who is a bad sleeper has OSA, but insomnia is even bigger than OSA, and we don't have a great way to track that right now, but RTM can do that. We've not used the RTM codes for insomnia, but what if you could, as a physician going through behavioral therapy for insomnia, have a way to bill the changes in their sleep? That's the future I'm painting here.
So Drew mentioned the hardware, and I think the next way to scale is actually more on the software side, in particular, artificial intelligence. So if you look at this slide here, I picture this. The left here is the inputs. This is what sleep professionals are looking at all the time, sleep coaches. We synthesize all this data, and then we manually determine what's the next steps, what are the escalations, what are we writing down, what are we recording. But AI can do a lot of that. It can pull all of this data and analyze it for us, which will help with the outcomes here on the right. So in doing that, it can help to provide prompts to really just reduce the mental weight of all of that clinical effort and clinical decision-making. Of course, not making any decisions for you, but just assisting in that process. So on the right side, you'll see future interventions. So right now we log into a system and we see compliance data, but in the future, it will not just tell you who is at risk and who is non-compliant, which is what we see now. It can recommend appropriate next steps for those patients, which is happening a little bit now with automations and triggers and rules, and that's all great. But with AI, it takes it a step further. So it takes massive amounts of patient data. It learns what has worked and what doesn't work. And then that will provide the guidance to what that recommendation might be. So for instance, that could be a mask fitting versus a mask change versus therapy change. And all of this is done with predictive measures and not just rules and triggers. Clinical documentation. Now, I don't know if you guys have seen it, but there are lots of AI scribes out there now. Some of them are awful. Some of them actually aren't even AI, but some of them are great. And they are becoming more advanced. SythPop, for example, of course, that's just what I know because I work for them. They can auto-generate transcriptions of visits, but they also can generate SOAP notes and after-visit summaries that, of course, need to be reviewed by that clinician before putting it in the EHR or sending it to the patient. But this is super helpful. I know from my experience, and maybe you guys have seen this as well, when you go to see your own doctor, half of the time they're typing on their computer or they're writing notes down because they need to document all of this stuff. But if we're really trying to improve that patient-provider relationship, if it could just take those notes for you and then prompt you what to say next, that would be incredibly helpful and really help with that engagement. It also potentially, with those prompts, it will be able to cross-reference payer policies and that patient's medical record, again, because it is learning all of this information. So imagine you are at a doctor's office and it is transcribing it for that doctor. It might show up on their screen to prompt certain questions to ask if they want to order a specific test or prescribe certain therapy or medication. Because again, we know that insurance companies make it difficult. We want to make sure we have as much information as possible to get all of the documentation needed, and that can be helped with AI. Lastly, health outcomes, of course, again, the main goal of everything here, but just imagine if every intervention, every improvement in OSA, all non-sleep health data like blood pressure, if all of this was automatically pulled and synthesized to show in incredible detail that treating OSA is a good thing to insurance companies.
Amen.
And by a good thing, I mean it should be prioritized. And what I really just mean is that it should be reimbursed for all of this effort. It is a game changer.
Oh, I put down that. Sorry. Found it. Okay, we're almost done, I promise. Yeah, we're at good time. So I'm gonna get on my soapbox for probably the 14th time. One of the things I've seen in CCSH is we spend 90% of our effort identifying the problem and 10% of our effort fixing it. And that's just not okay. I mean, what if oncology was like that? Like, hey, you have cancer, here's your script for chemo, good luck, figure it out. I mean, that's kind of what a lot of patients are dealing with sleep apnea. It's heartbreaking, honestly. And the reason we're up here is we think that RPM can move that needle. That's where, but if that is the solution, how do we do it? We have millions of patients on CPAP. There's a 0% chance that if we were to try to get every single patient on RPM, that insurance company is going to pay, you know, what's the average, like, yeah, $100 per patient per month for millions of patients. So this is where, and I think Mark might get more into this later on, but this is where, does everyone here know what value-based healthcare is, or can I give a quick? Yeah, so fee for service is what we all know. You know, you do a sleep study, you get paid for the insurance company to do that sleep study. All right, you provide a patient with a CPAP machine, you get paid for giving a CPAP machine. Value-based healthcare is different. Value-based healthcare is when you say it's risk-based. You go to the insurance company and you say, hey, give me all of your OSA patients. All right, I'm going to treat them however I want to treat them, and you just pay me this much money for it. All right, that's the move for us. All right, we know how to manage these patients. We know with all these tools out there and the tools that are coming, we can do it better, faster, more efficiently, and cheaper than the insurance companies, because we don't need to jump through all our hoops. If we imagine never having to do a prior authorization. Wow, right? I'm gonna say, imagine that. That's what value-based healthcare can be. It's the doctor saying, I think this is what the patient needs, and I'm the expert, so I'm going to do this. So all that to say, if we have access to all this data that the patients have, you know, let's say it's from the device in their house. If we have AI that's able to synthesize all that data quickly and guide someone into what to do it, that's where this can actually scale. All right. So the goal here is we want to build that scalable system that can save the health, even the payers, save them money, but actually be able to provide the care that patients need. I know it's crazy. I'm a dreamer, but you know we're hopefully getting there. So that's what we think the future of our is.
I think that's it. You're on.
I think we're out, and we got like 10 more minutes. We can actually. Yeah. Thank you. Yeah, we love to. Can we do questions? Yeah. Anyone have questions? If you want to, I can actually walk over to people. Okay.
Thanks, Cody. You guys for feeling forward. Do you do a face-to-face over the phone with those patients?
Yeah, so those codes, the ones that require the communication, we're doing either a phone call with them or video call. Yeah.
Every month.
Every month, yeah. And sometimes sometimes that is at the end of the month. Even if they're doing well, we know there are sometimes patients that are doing well, but they might actually, I actually have patients, who, you know, I call them and say, hey, it looks like you're wearing your machine every night, your AHI is down, you feel me, everything's good. They're like, yeah, my nose is bleeding every day. I'm like, oh, so that's a thing. Yeah, we should address that. And so that's why even if most likely the data they're doing well, it's really important to check on every month because if they're putting a Band-Aid on their mole scanners, check something. Any other questions? We have a question in the back.
So if anybody's thinking about doing something like this, there are different, I don't know what you call them, like apps that can key in with your EMR. And so it will calculate that time with you. Every time you go into that chart, that calculator starts up. So it really covers your trails to make sure you have proof that you were in this patient's chart, you document what you did, document you talked to them, whatever files you pull over your data, you're able to put that in the chart. It all keeps together. That way, if you ever get audited, it's all there. And it keeps track for you. So every month you run a report. It shows you how much time you spend on each patient. You can grab that and build those out. And then for the next month, anybody that didn't qualify, those go over to the next month and you go to bill again.
Yeah, great point, great point. Oh, water point. What's the reimbursement? Here we go, reimbursement. So as I said, the average is somewhat, it's gonna be somewhere between $100 and $150 per patient per month. All right. Less for Medicare, yeah. Medicare's always, I mean, plus or minus 20%. Some of the commercial payers with 10-year contracts. And it doesn't seem like a lot. All right. But when you're talking about thousands of patients, this is absolutely something. And especially it's important if you are in a practice or that's doing a lot of this work already. Then all you have to do is document appropriately. And as there are tools to do that, then you consider these things. But it's between 100 and
I think that's a really important point. I just want to harp on that for a second, is that we're not getting rich from doing RPM per patient. We do bill more the first month. Again, those higher codes, we do see less afterwards, closer to like $100, we'll say. It is a volume game, but again, we know that most of you are doing this already. We know that a lot of practices are doing this already, but you're getting paid $0 right now. So 100, 150 is actually quite nice to get paid for the work that you're doing, as long as you are also, of course, documenting. So it adds a little bit more work, but not much.
And really the goal here is to do this right now, speed the service model, show that it works, show that we're really helping patients. And so once we hit that critical mass of doing this for a lot of patients, then we can move over to the value-based and risk-based healthcare and go to the payers and say, you know, you can either pay $1 million to manage these patients or in this fee for service, or you know, maybe $500,000. And then I'll take $500,000 anyway. It keeps going, yeah. And so, yeah, like we said, we have patients like that we keep up for like 30 to 90 days, and then they drop off. But guess what? There's more patients. Yeah.
There's always more patients.
Any other questions? Oh, water right here.
I'll stay up here. Thank you.
I'm kind of these new shoes.
I do believe in work. I was a healthcare coach and case manager for Boston Shield of Massachusetts for 6 years. And I worked for a contracting company for disease management called Healthways, and it works. It works, and this could be implemented for those payers.
Absolutely. I mean, do you know how much it costs them when a patient doesn't use their CPAP and then gets into a car accident or has a heart attack or has to be admitted to the hospital? Way, way more. Okay.
Yeah. So the question for what you guys do you guys implement, like you have databases where you have sleep techs working on them, or how do y'all handle?
Yeah, to actually monitor patients. Yeah, we do need to use a few different systems because we are a third party. We're not in anyone's practice. And I do think it's a little bit more complicated for platform that does take all the CPAP data from several different companies, well, the 3 companies. So we monitor the patients in that platform. We also reach out to the patients in that platform because that is thankfully doing all the time reporting for us. We do the charting notes there. Then we also have to manage the tasks. Again, what is the point of doing all this work if we don't do something to help the patients, we don't intervene? So we will monitor them in a platform, communicate with them there, assign tasks to different coaches, and everything is remote, so everything is very transparent. Even in the like text messages that we send to the patient, different coaches can all be on that text thread, and you'll see who sends messages, so it's very clear who's doing what.
Yeah, and I'll throw out this point. Our business partner is not in the oral science space, and so when we were trying to figure out that, so how do we train all of the coaches to help these patients on CPAP? And I like kind of like looked to them sideways. I was like, you don't need to train a sleep tech to be a sleep tech. Like we know this stuff. Like every single like message we get, it's so obvious. Like if you've been a sleep tech for a couple of years, like a patient says, you know, hey, like my mask is leaking out of my ear. You're like, well, don't put it on your ear. Try your nose instead. Like we know what we're doing here. So there's not a lot of training. You literally just get to be yourself and help patient after patient. It's incredible. I know we're talking a lot about like the dreaming and the logistics here, but like, man, there's nothing better than having that patient like reach out to you and be like, wow, that little trick, you told me to pull the headgear lower on my head and now I can use CPAP, you know? It's incredible. It feels so good. So
I hope that answered your question.
we have one more.
So I am doing RPM with insomnia. Have you heard of the sleep device? So we're using that as the actual medical device in the patient's house to acquire the objective data, and then I meet with the patients doing the CPI. So
Are you an RPSGT or?
yes.
Wow, this is
I want more RPSGTs to not think about OSA and realize that there are so many patients with insomnia, and so many patients are both insomnia and OSA. So kudos to you. I think any of you, if you Google like CPTI training and certification courses, there are some online. It's growing fast. It's going to be a need. But if you work for a sleep lab, don't quit. There's not enough sleep techs out there. I have to. So, but yeah, just in the future. Okay. Okay. Well, good. Thank you, everyone.